So, what is derailed cerebral ischemia? So, 1 to 3 days is early ischemia, and then after that 3 to 14 days or 4 to 14 days as per some texts can be post-ictus is delayed cerebral ischemia. This is vasospasm, and it can be, as mentioned, clinical, radiological, or both. So, whenever we do an angiogram to diagnose an aneurysm, we also look at the vessels, how the vasospasm is in the ACAs as well as the anterior cerebral arteries as well as the middle cerebral arteries, see if there is any thinning of the A1s or the M1s. We are most concerned about the vasospasm in the A1 and the M1, that is the more proximal parts of these vessels, and we do have to follow these vessels up to the convexity and see how the vasospasm is up to the distal ends. So, it is prudent to diagnose vasospasm early, and a radiological diagnosis, even in the absence of clinical vasospasm, may need to be treated aggressively. Whenever there is a patient who is having hemiparesis or weakness, transient weakness, it is very essential to confirm the diagnosis of a clinical vasospasm with radiology and go ahead and treat the vasospasm with either an intraarterial nimodipine or intravenous milnirone. So, the incidence of this, as we all know, is around 30%, and it depends on the volume of the bleed, so and also the Fisher grade on the CT. So, early brain injury, the patients who have had early brain injury and who present with hemiparesis, definitely these patients are the ones who have aggressive vasospasm, which probably is sometimes refractory to treatment. As I mentioned, other organs may be affected. Lungs can have pulmonary edema, ARDS because of the inflammatory changes. Hearts, generally there are patients who have come with an LOC, an ECG being done showing ECG changes, arrhythmias, and then treated for the heart rather than the brain, rather than getting a CT done. So, these case reports have also been seen, and rarely they also do have MI because of the systemic effects of the acute subarachnoid hemorrhage. There are other organs which can get also affected, the kidneys going into renal failure because of the severe systemic inflammatory response syndrome, and once this sets in, the prognosis is really guarded. So, as we went through, the presenting symptoms are usually headache. It is an instantaneous headache which is acute onset, and thunderclap headache, and this is usually associated with vomiting because there is raised ICP, and the vomiting usually relieves the headache because of the hyperventilation associated. There is neck pain in some patients because of the blood in the subarachnoid space. Sometimes patients do complain of photophobia or phonophobia because we see a sleeve of subarachnoid space accompanying the optic nerves, and this causes them to have photophobia because of the presence of blood in the subarachnoid space. There may be a presentation with altered or transient level of consciousness, as we already went through in the pathophysiology. That is because of a transient global ischemia which happens, and the patients present to you with altered sensorium. Sometimes the altered sensorium may be because of hydrocephalus and hyponatremia, as we already went through. So, meningism is not because of infection. Sometimes it is misconstrued that the patient is having headache and altered sensorium because of meningitis. It is actually very well documented thing that because of the blood in the subarachnoid space, the patient does have positive meningeal signs, but one must not get fooled with the diagnosis of meningitis. They will present with focal neurological deficits if they have had significant early cerebral ischemia. Sometimes they may present 3 to 4 days later, and the presentation may be focal neurological deficits. Sudharsan had reported vitreous hemorrhage associated with Sudharsan's hemorrhages, had reported vitreous and other intraocular hemorrhages associated with subarachnoid hemorrhage, and this has been described in about 5 to 10% of patients presenting with aneurysmal subarachnoid hemorrhage. Whether exertion is a risk factor has been studied in several retrospective studies, where they have found that maybe 40% of patients had exertion or some form of physical exertion prior to the rupture. But there isn't sufficient evidence to advise patients who have been diagnosed with unruptured aneurysms not to exert themselves. So, I think they should just lead their lives normally. But once an aneurysm has ruptured, it is pertinent that we put them on bed rest and not exert them. There should be minimal stimulus, as we will be seeing their management in the upcoming slides. So, based on the location, the aneurysm can have certain specific findings. So, when there is bilateral lower limb paraparesis or paraplegia, it can be because of an ACOM aneurysm. Similarly, a PCOM aneurysm will present with third nerve palsies because this artery and the aneurysm are closely related with the third nerve. The anatomy of the third nerve is also very important because the third nerve, the pupillary fibers are usually in the periphery. So, whenever there is a surgical cause, an aneurysm causing its compression, the pupillary fibers are involved and it causes a complete third nerve as against the vasa vasorum. So, vasa vasorum, which is usually affected in diabetes commonly, metabolic causes of vasculopathy, the pupillary fibers are spared. So, if you see a patient presenting with a third nerve, complete third nerve with pupillary involvement, you should suspect a surgical cause such as a PCOM aneurysm. MCA aneurysms usually present with hemiparesis, and if it is the left side, they may present with aphasias. So, these are certain hints to the location of the aneurysm, but they need to be confirmed on an angiogram. IC aneurysm sometimes presents with field deficits because of the compression on the chiasm or the optic nerves. Supracerebral artery have a very similar presentation to PCOM aneurysms, where they can present with third nerve dysfunction. The WFNS grading has been traditionally used way back from the 1988 when the World Federation of Neurological Surgeons suggested or proposed this SAH scale, replacing some of the multiple scales which are being used for grading these SAH patients. So, as shown in this figure, we see that WFNS grade 1 is a patient who is with intact sensorium, 15 by 15 with no deficits. When they have certain mild altered sensorium, like when their GCS 13 by 13 or 14 with no deficits, is grade 2, but when they have deficits, it is grade 3. So, these 3 grades are good grade aneurysms and 4 and 5 are poor grade aneurysms. By deficits, we remove the third nerve and sixth nerve paresis, which may be false localizing signs sometimes, and sometimes the third nerve paresis is because of the actual aneurysm, that is a PCOM aneurysm or a superior cerebral artery aneurysm. So, these 2 deficits are not considered neurological deficits, whereas a hemiparesis, an aphasia or a paraplegia is considered a motor deficit, and if it is present, it goes into WFNS grade 3. Any patient with a sensorium of 7 to 12 or whose comatose 3 to 6 are all poor grade aneurysms, WFNS grade 4 and 5 respectively, and they may have motor deficits or no motor deficits, they are all poor grade aneurysms. So, it is interesting to note that this WFNS grade is usually done after resuscitating the patient sufficiently. The patient would have been in loss of consciousness for some time. It is pertinent that we correct the hyperglycemia, hyponatremia, the airway breathing issues, and after sufficiently resuscitating the patient, sometimes the patient will have hydrocephalus. After putting the EVD, the sensorium will improve, and then you decide whether this patient is really poor grade or not. Poor grade aneurysms are generally very large bleeds, and the best of interventions may not help such patients. They need to be counseled in detail, and after that taken up for an interventional procedure to prevent a rebleed, and probably be managed intensively for 2-3 weeks in the ICU, and after that the rehabilitation course is pretty long. So, that is why the differentiation happens between good and poor grade aneurysms. It is probably not to deprive the patients with grade 4, grade 5 aneurysms of any treatment, but it is a very important tool to counsel the patients at the time of admission that the outcomes may be long drawn and they may be need prolonged rehabilitation. So, I think this WFNS grading is very important to counsel the patient in the ED and differentiate between the various types of aneurysmal subarachnoid hemorrhage. So, the imaging findings as defined by Fisher in his landmark article were we have 4 scales on the Fisher's grade. Fisher 0 is nothing but was given in the modified Fisher grade, where they wanted to put a normal CT into this. Fisher grade 1 is usually when the CT is normal in the traditional Fisher grading. So, if we have a thick subarachnoid blood, it is grade 3. If it is thin, that is less than 1 mm thickness of subarachnoid hemorrhage, it is Fisher grade 1. Sometimes you find blood in the ventricles or in the brain parenchyma. So, intraparenchymal hemorrhage and intraventricular hemorrhage both are considered Fisher grade 4 classically. Sometimes the modified Fisher's grade is used just to define the amount of vasospasm. We generally prefer to use the Fisher grade. Modified Fisher grade does not add much of value, except that when the IVH is present, it is present in grade 2 itself, because IVH may not determine the amount of vasospasm that the patient has. To briefly predict how much percentage of chance that the patient has for developing vasospasm, Fisher scale is very useful. So, there is a 40% chance, nearly 40% chance for a patient who is having a Fisher grade 4 bleed, that is with intraparenchymal or intraventricular hemorrhage, the chance of them developing vasospasm is very high. So, I roughly remember it as 20, 20, 30, 40. So, 20, 20, 30, 40. So, whenever you have a bleed, there is a 20% chance of you developing a vasospasm, and it is 30 when it is Fisher grade 3 and it is 40 when it is Fisher grade 4. So, what is the role of LP in these patients? Generally, it is done when the CT scan is negative and you have a very strong suspicion of a subarachnoid hemorrhage. Even in that case, I would go ahead and do a CT angiogram or a MR angiogram or a digital subtraction angiography rather than do an LP in these patients. So, it has relatively less value nowadays. So, what you can do when you are doing an LP is you can measure the opening pressure, but a CT, which is on the basis of which you decide to go ahead with an LP, confirms no hydrocephalus prior to the LP. So, it can be done in a delayed presentation when you are suspecting a sentinel bleed with a normal CT. Then you can do an LP and look for xanthochromia and no clots. If there are clots, it may be a traumatic tap. If in case you are suspecting a traumatic tap, go to another level, and if again in the other level also you are getting blood, it looks most likely like a subarachnoid hemorrhage rather than traumatic tap at every level. So, usually the blood stays for long and it may be positive in up to a week to 2 weeks post subarachnoid hemorrhage. The role of MR imaging is also relevant in very fine and thin bleeds. These are usually seen in the flare sequences as shown here. You can nicely see flare sulcal hyperintensities on T2 weighted flare imaging, and these small bleeds are really picked up well in flare imaging rather than a plain CT brain. So, if I find a negative CT in a patient whom I am suspecting a subarachnoid hemorrhage, I would rather do an MRI with an MR angio, which can be a TOF or a contrast based angiogram. So, that will be my next investigation rather than an LP. So, angiography can be a CT angio. Many surgeons prefer to do a CT angio and decide surgical plans based on the 3D CT reconstructions. MR angio is not as good as the CT angio. So, it is probably actually I would put it number 3 in the list of angio investigations that I can do. Digital subtraction angiography is a very useful tool because you have the runs which are available. So, based on the runs you can decide which is the dominant side, and you can plan your surgery based on the which side is the dominant vessels. And also the angiogram gives you additional information on compression tests, which we will not be having when you plan your surgery or coiling based only on the CT. So, the compression tests are very essential for planning surgery to decide which side you are going on, and and also to decide where to place your proximal clip and whether you can sacrifice the ICA in case of an introp rupture, a very bad introp rupture. You have no other choice but to sacrifice the ICA. So, moving on to management, I would admit the patient in an ICU or a high dependency unit, preferably a less stressful one where there is less noise and a dark environment, and then I will keep the patient on strict bed rest, probably keep the patient NPO because we will be planning surgery in 1 to 2 days, and the head of bed can be elevated by 30 degrees as a nursing measure to reduce the ICP. we have to reduce all the stimuli. So, we tend to avoid a Foley's catheter on a nasogastric tube wherever possible. Intravenous fluids with a goal to maintain euvolemia, not hypervolemia, is the standard of care now. So, you will start them on IV fluids and keep them on NPO. Unless the patient is intubated, or I will intubate only if the patient's GCS is less than 8, because the sensorium and the deficits can be assessed regularly. And if the patient is intubated, you can go ahead and put a Foley's catheter and a nasogastric tube if found essential. So, the 3 H's, as I mentioned during my talk: hydrocephalus will require an urgent EVD, hyponatremia will require gradual correction, and hemiparesis, you should look for vasospasm. Sometimes it might set in early than the traditionally described 4 to 14 days, and you would have to treat it aggressively. So, ICU care involves monitoring vitals, GCS pupils on an hourly basis. Intake output has to be monitored every hour to ensure euvolemic fluid resuscitation, and the maintenance of body temperature, avoidance of fever, hyperglycemia, hypoxia, and decreased cerebral perfusion pressures are very important. Hypovolemia is definitely avoided. Some people tend to still keep some amount of positive balance and hypovolemia, and hypernatremia is also avoided. Generally, we keep the sodium levels more than 140. So, you can start off 3% if you feel the sodiums are around 130, and give them either as boluses, that will be helpful, or you can run an infusion at 10 ml to 20 ml per hour. So, some centers tend to keep the sodium even higher at 145, but 140 to 145 is a target that you must have. Daily body weight measurements are also helpful in assessing the hydration status of the patient. Arterial catheter generally is not inserted in the ICU just to avoid another stimulus, to avoid a re-rupture, but it can be inserted for poor grade patients, that is grade 4, grade 5 WFNS patients. You can do it preoperatively and it under adequate sedation. The sedation should be short acting so that you can still continue to assess the GCS of the patient. After anesthesia in all patients for surgery, you need to place arterial catheter. That is very helpful in maintaining the blood pressures and maintaining a map of around 100, more than 100 at least, even post-op, to prevent vasospasm. Preoperatively, I would not keep the map very high. I would target a map of around 90 because the aneurysm is unsecured. I do not want to push the map too high and cause a re-rupture. Central venous line is always required post-operatively. Even for managing intraoperatively, central venous line is required. So, 4 drugs are definitely given when once I diagnose a patient with acute subarachnoid hemorrhage. I write the 4 drugs then and there whenever I see a acute subarachnoid, aneurysmal subarachnoid patient in the casualty. I start them on an antiepileptic, which can be stopped after a week if there is no history of LOC or history of seizures. Analgesics, preferably paracetamol. There are centers which do give opioids, but the problem is the sensorium may get affected. You give paracetamol boluses of 1 gram, and usually it works well and brings down the pain, especially in patients who are of good sensorium 14 or 15. Once you give opioids, you do not know whether the sensorium is dropped because of one of the 3 H's that we have described, or it is because of the opioids. So, that is one of the reasons why we give just paracetamol. Laxatives and stool softeners are given to prevent unnecessary straining by the patient. Nimodipine is continued up to 21 days post-ictus. It is given at 60 mg Q4H, but if this is causing too much hypotension and map is falling, you can make it 30 mg in more frequent intervals, maybe Q2H, 30 mg you can keep giving if there is hypotension. Antihypertensives are preferably stopped. Actually, many of these patients are hypertensives. You can stop the antihypertensives for a few days, because the map has to be maintained above 90. Labetalol boluses may be given if the PP is too high until the aneurysm is secured. Once the aneurysm is secured, map of 100 is a general principle which is followed in many centers. So, what are the adjuncts which are used in the ICU? One is the transcranial Doppler. This is a surrogate for vasospasm, may not be the perfect surrogate, it is highly operator dependent. So, if it is done by the same operator and the same machine, it can be used to establish a baseline and serially monitor for vasospasm when the patient is in the ICU. So, once you see a dropping flow in the MCA, I think that's one of the most significant rather than to go by the Lindegard ratio. So, it is very operator dependent, and it is definitely useful once you have a baseline and you monitor it the same way. It is definitely useful then, rather than rushing the patient to the IR suite for an angiogram every time we suspect vasospasm. So, digital subtraction angiography with cost compression tests are very useful. Intravenous milrinone can be started based on the Montreal protocol described in 2012 by this group. It is a continuous infusion which is usually run, and it started early, and they are very aggressive in treating vasospasm according to this protocol. This can be given, and the protocol even describes what to do in refractory patients. So, now the next step will be to put in an intraarterial pneumodipin. This can be done only in the IR suite. You inject it, generally it is given in boluses of 1 to 2 milligrams, and they are given as close to the vasospastic area as possible. Usually you can even choose which vessel is more vasospastic, A1 or M1, and give it at right at that place so that the radiological vasospasm improves. You can see an immediate improvement in the angiogram, and before you come out you can ensure that you do a check angiogram to show improvement in the vasospasm. Sometimes in refractory cases where you have tried 2 or 3 doses of intraarterial pneumodipin, you have no choice but to put an indwelling catheter and keep giving them pneumodipin through the indwelling catheter, which may be placed at the ICA or just at the bifurcation of the ICA. The only risk with this is you need to keep giving heparin, and you would have planned surgery, and if the patient is post-op, then the real worry is the vasospasm is so bad that it sets up infarcts and you have to decompress. You would have given heparin and you would have to reverse that. So, that is the issue with indwelling catheters, and they can cause obviously thrombosis along the catheter line and the risks associated with the same. Microdialysis, brain tissue oxygen levels, continuous EEG are not routinely done, but they are definitely done in the research settings. So, complications, as we have already seen, and this is just a slide to conclude and bring all the complications into one slide. So, hydrocephalus will require CSF flow diversion. This can happen during the 3 weeks that you observe the patient post an aneurysm rupture. So, CSF flow diversion, the acute setting is managed with an EVD, but even despite the EVD, the patient does not improve. Some of the patients, around 5% of them, do require shunts. And vasospasm, they may be refractory and they can develop infarcts, and this infarcts, once they are very extensive, you have no choice but to decompress the patient. Rebleed is a possibility whenever the patient's sensorium drops. Once you have removed the possibilities of a hydrocephalus or a vasospasm or a hyponatremia, rebleed is a definite possibility. A CT scan will reveal that, and you have no choice but to quickly go in and secure the aneurysm, because the chance of rebleed, once the patient goes in for a rebleed, they generally do not do well. So, non-neurosurgical complications can be multisystemic. One is respiratory, that can be pulmonary edema, pneumonia because of the intubations, and post-operatively also. Pulmonary embolism is also a possibility, as we have discussed in the previous slides. Cardiological problems like arrhythmias can happen, and these are all symptomatically managed. Very rarely MI or cardiac failure can also be a cause of death in these patients with aneurysmal subarachnoid hemorrhage. Dyselectrolytemia is usually because of diabetes insipidus or cerebral salt wasting. This is the usual cause for hyponatremia, and that is corrected symptomatically, and it should be done gradually. No more than up to 10 milliequivalents should be corrected in a 12-hour period, and it is gradually done, and it is kept high so that hyponatremia does not set in early. Hyperglycemia is also needs to be corrected aggressively. Many of these patients do develop hypoglycemia during the subarachnoid hemorrhage, and this needs to be monitored. Anemia also needs to be corrected, so that usually we do not correct it with blood transfusions, but anemia, if it is too low, may require very rarely. DVT is another complication which should be watched out for, and pneumatic stockings and regular compressive stockings also can be of use in these patients. Thank you.